In this video, you will learn about the structure and function of the thyroid gland. We will start with the normal structure of the thyroid gland and the major functions of the thyroid hormones. Then we will look at disorders of the thyroid gland, including Graves' disease, iodine deficiency, and Hashimoto's disease. The thyroid gland is a butterfly-shaped endocrine gland located in the anterior cervical region. It plays a central role in regulating metabolic rate and supporting normal growth and development. The thyroid gland produces three major hormones: calcitonin, thyroxine, and T3. While calcitonin contributes to calcium homeostasis by lowering blood calcium levels, thyroxine and T3 regulate metabolism. The functional units of the thyroid gland are called follicles. Follicles are sphere-shaped structures lined by a simple cuboidal epithelium of follicular cells. These cells surround the follicle and are responsible for thyroid hormone production. Parafollicular cells are found in the connective tissue between thyroid follicles and function to produce calcitonin. You will learn more about the role of calcitonin in calcium homeostasis in another video. This video will focus on the thyroid hormones, thyroxine and T3, that regulate cellular metabolism throughout the body. Inside each follicle is a protein-rich substance called colloid. Colloid serves as the storage site for thyroid hormone precursors. Thyroxine is also known as tetraiodothyronine, which can be abbreviated T4. T3 is short for tridothyronine. There are 4 iodine atoms in the structure of thyroxine and 3 iodine atoms in the structure of T3. Thyroid deiodinase is an enzyme that removes an iodine atom from thyroxine, producing T3, the active form of the thyroid hormone that binds to intracellular thyroid hormone receptors in target cells. Although thyroxine and T3 are amino acid-based hormones, these molecules are hydrophobic and require binding proteins to travel in the blood. The major component of colloid is a tyrosine-rich protein called thyroglobulin that serves as a precursor to thyroxine and T3. Iodide ions are actively transported into follicular cells. An enzyme called thyroid peroxidase oxidizes iodide ions, producing iodine. Iodine then binds to tyrosine residues on thyroglobulin. When stimulated, follicular cells convert iodinated thyroglobulin into T3 and T4. The hypothalamus and anterior pituitary work together to regulate the production of thyroid hormones. TRH is the releasing hormone produced by the hypothalamus to stimulate the secretion of TSH. TSH stimulates thyroid hormone synthesis and secretion. TSH also promotes growth of the thyroid gland. T3 is a hydrophobic hormone, so it binds to intracellular thyroid hormone receptors in target cells. Then, the activated receptor hormone complex enters the nucleus to regulate the transcription of genes involved in metabolic rate, cardiac output, growth, and brain development. Mitochondrial uncoupling proteins increase metabolic rate by allowing hydrogen ions to leak across the inner mitochondrial membrane. This reduces ATP production efficiency and increases heat generation. The sympathetic nervous system increases cardiac output through adrenergic receptor activation. T3 increases the number of beta-1 adrenergic receptors in cardiac muscle. This makes the heart more sensitive to norepinephrine and epinephrine. Brain-derived neurotrophic factor supports brain development by promoting neuronal growth and survival. The levels of thyroid hormones in the blood are regulated through a negative feedback mechanism involving the hypothalamus and anterior pituitary gland. When body temperature is low, the hypothalamus secretes TRH, leading to release of TSH and increased production of thyroid hormones. While increased metabolic heat production can help to remove the stimulus for TRH production, T3 also binds to receptors in the hypothalamus and directly inhibits the secretion of TRH. By increasing metabolic rate, T3 helps to maintain body temperature homeostasis. When body temperature falls below the homeostatic set point, the hypothalamus sends commands to effector organs that work to increase body temperature. While the blood vessels redirect blood flow to prevent heat loss, increased metabolic rate in skeletal muscles generates heat. The commands to increase heat production involve shivering, where the nervous system stimulates muscle contractions. T3, produced by the thyroid gland, is another signal that causes muscles to increase heat production, as increased expression of mitochondrial uncoupling proteins increases metabolic heat production. Hypothyroidism occurs when insufficient thyroid hormones are produced. Common symptoms can include cold intolerance or feeling cold when the environmental temperature is comfortable for other people. Feeling unusually tired and weak, poor memory, and short attention span. Observable signs may include weight gain, hair loss, swelling, decreased heart rate known as bradycardia, and overgrowth of the thyroid gland known as a goiter. Congenital hypothyroidism occurs when a child is born with low thyroid hormone signaling. Early signs include excess sleep, low body temperature, jaundice, large tongue, umbilical hernia, and large fontanelles. Thyroid hormones are important for growth and brain development, so untreated congenital hypothyroidism leads to developmental delay and mental impairment. Treatment for hypothyroidism depends upon the underlying cause, but iodine supplementation or thyroid hormone replacement therapy are the most common treatments. Insufficient dietary iodine intake causes hypothyroidism because deficiency limits thyroid hormone synthesis. This occurs because iodine is required to produce T3 and T4. Negative feedback is reduced in this condition. This results in increased TRH and TSH production. A goiter may develop in hypothyroidism due to excess TSH stimulation. Low urinary iodine levels can help diagnose deficiency. Iodized salt has greatly reduced the prevalence of severe deficiency. However, mild iodine insufficiency remains common and clinically important in many parts of the world. Hashimoto's disease, or autoimmune thyroiditis, is an autoimmune disorder affecting the thyroid gland leading to hypothyroidism. In this condition, immune-mediated destruction impairs thyroid hormone production. The self-reactive B lymphocytes produce autoantibodies that bind to proteins in the thyroid gland. Thyroid peroxidase or thyroglobulin autoantibodies commonly assist with diagnosis of Hashimoto's disease. In some cases of Hashimoto's disease, antibodies block the TSH receptor, preventing activation. Ultrasound of the thyroid gland can also help with diagnosis of hypothyroidism. In Hashimoto's disease, the thyroid gland often becomes overgrown and cystic, but in some cases, the thyroid gland will become smaller as it atrophies. Here we see the histology of the thyroid gland from a patient with Hashimoto's disease. This is characterized by lymphocyte infiltration and decreased size of the thyroid follicles. Hashimoto's disease removes the negative feedback, leading to increased secretion of TRH and TSH. Increased TSH often leads to growth of the thyroid gland, causing a goiter. The primary treatment for Hashimoto's disease is thyroid hormone replacement therapy. Although iodine deficiency and Hashimoto's disease are the most common, there are other causes of hypothyroidism. In primary hypothyroidism, where low thyroid hormone levels result from dysfunction of the thyroid gland, TSH levels are typically elevated. In contrast, central hypothyroidism is when a dysfunction of the pituitary gland or hypothalamus leads to low TSH levels. Hyperthyroidism occurs when excessive thyroid hormones are produced. Symptoms may include heat intolerance, irritability, anxiety, insomnia, and increased appetite. Clinically observable signs of hyperthyroidism include weight loss, tremors, tachycardia, goiter, and bulging of the eyes known as exophthalmos. The most common cause of hyperthyroidism is an autoimmune disorder known as Graves' disease. In this condition, the immune system produces TSH receptor autoantibodies. These antibodies mimic the action of TSH. This leads to excessive production of T3 and T4. Here we see the effects of Graves' disease on the histology of the thyroid gland. Follicles and follicular cells are enlarged as their activity is increased. In Graves' disease, negative feedback suppresses TRH and TSH production. The presence of TSH receptor autoantibodies in a patient with hyperthyroidism would support a diagnosis of Graves' disease. Treatment with anti-thyroid medications is often the first choice, especially in younger patients or those with mild disease. Corticosteroids may be used to help reduce ocular inflammation as a treatment for exophthalmos. There are also newer biologic medications available now that target specific inflammatory signals. Radioactive iodine therapy is another option that works by selectively destroying thyroid tissue, gradually reducing hormone production. Surgical removal of the thyroid gland, a procedure known as thyroidectomy, can also be used to treat Graves' disease. Medical thyroid replacement will be necessary to treat hypothyroidism following radioactive iodine therapy or thyroidectomy. Although Graves' disease is the most common, there are several potential causes of hyperthyroidism. Radioiodine scanning produces an image showing the distribution of iodine uptake in the thyroid gland. Graves' disease leads to increased iodine uptake evenly distributed through the thyroid gland. Toxic multinodular goiter is the second most common cause of hyperthyroidism. This leads to uneven iodine uptake concentrated in clusters of overactive cells, forming nodules. This occurs more often in older patients following chronic iodine deficiency. Toxic adenoma is a benign tumor that forms a single mass of overactive cells. Inflammation of the thyroid gland, known as thyroiditis, can stimulate the release of thyroid hormones, leading to hyperthyroidism. However, thyroiditis decreases production of thyroid hormones, so it may progress to Hashimoto's disease. While TSH levels are usually suppressed in hyperthyroidism, secondary hyperthyroidism is a rare condition that occurs when a tumor forms in the pituitary gland, producing excess TSH. Although negative feedback inhibits TRH secretion, the tumor continues to produce elevated TSH, causing hyperthyroidism. In summary, thyroid hormones regulate metabolic activity, cardiovascular function, and normal development. Because these hormones influence nearly every tissue in the body, disorders of the thyroid gland produce widespread systemic effects.